right, hello. This is Monika Friedman and Dr. Eric Surrey from CCRM in Colorado. Hello, Dr. Surrey. Thank you so much for your time today.
It's a pleasure to join you.
Thank you so much. I know that you're a very busy man and doing very important things. So in the next 20 to 30 minutes, we're going to look at a few frequently asked questions that I get from my clients in my capacity as a fertility coach. And you probably have so much knowledge and expertise to share. If you could introduce yourself, please.
Sure, it's my pleasure. Well, I'm a board-certified reproductive endocrinologist. That means I've completed residency in OBGYN and then took a fellowship with specific training in this field. And I did all of that training at UCLA in Los Angeles, and then had been on faculty at UCLA for several years and running the in-vitro program at Cedars-Sinai Medical Center in Los Angeles, and then another private program in LA. I joined CCRM in 1999, and I'm the medical director at our main facility in Lone Tree, and it's been a joy to be out here for any number of reasons, not to insult anybody from Los Angeles, but it's been a joy. And our particular interests have been folks who have struggled maybe a little more than average, who've had unsuccessful cycles. Additional personal interests of mine is women with endometriosis who have fertility issues as well, and folks that don't respond quite as well. So I'm delighted to help in any way that I can.
Thank you so much. All right, let's get started. One of the questions I get from my clients is, which fertility clinic should I choose? And then obviously CCRM is known as one of the best out there. So what is your success rate?
Well, you've asked me two questions really. And in terms of how someone should go about finding a fertility clinic, everybody should come here, of course, but being more objective, I think it's very important for a prospective patient to do research. The typical thing is my doc referred me, or a friend referred me, it's more convenient, all those things are reasonable, or I saw an ad. But I think it is critical to figure out, one, are you the right fit for that clinic, and vice versa? Now, certainly, I feel it's absolutely critical that a clinic be a member of SART, Society for Assisted Reproductive Technologies, because those clinics have to report their success rates in a specific way. All clinics do to the government, but they report to SART. They have to follow specific practice guidelines, advertising guidelines, ethical guidelines. That's key. The other is to kind of figure out, well, if I look online and I'm 44 and the clinic has taken care of 3 44-year-olds in the last year, that might be the right fit for me. And then I think in that there's no harm in doing an initial consultation, doing multiple initial consultations. You have to feel comfortable and feel that your questions are being answered and you're being treated as an individual. So that's part A of the question you asked me. Part B is, what is our success rate? And it's interesting, that question gets asked a lot, and it's not an answerable question, and it's not to fudge the answer, but everybody's success rate is different. So our overall, what's our number for everybody is a meaningless number. It's, what is it for you as an individual based on your age, your evaluation, your past history? And that we can be very precise about, because it really does change based on age for sure. And now that we can do things like chromosomal testing of embryos, the chance of having normal embryos changes. So it's very hard to say, here's the number. It's easy to get that number, but it's not that meaningful.
Right. So a lot of my clients are over the age of 40 years old. Can you give us any indication of how many women of yours or your clients or your patients are over the age of 40?
I would say probably the majority would be over 39. We do. And to get to your question of success rate, I'm going to break it down, which is what I do with all my patients, into not one number, but a couple of numbers. I strongly advise that women who are 38 and over do chromosomal testing of embryos. So I look at it almost like a an obstacle course of what's the likelihood you're going to finish the obstacle course. So if you only got one obstacle left, that's pretty good. And so if I know that that woman has a normal embryo, her chance of having a baby, not just getting pregnant on average, is 65%. And it doesn't matter what her age is. But if we back up the obstacle course to say, okay, we don't know if you have normal embryos yet. We haven't done in vitro fertilization. What's the chance that any one embryo would be normal in a 40-year-old? It's about 40%.
Got it.
Now, if that woman was 30, it would be the same 65%. But her chance of having a normal embryo jumps up to 75%. So that's why it's so important to treat folks as individuals. It makes for a more complicated answer, but I think a much more meaningful one.
Okay. And that is tied to my next question. What is the one tip, if there is one, maybe that's a trick question, for over 40 years old to improve their chances of IVF?
Right. Well, first of all, you have to know where you stand in the first place. So I think, 40 isn't 40 isn't 40. It's true for all of us, no matter what it is, whether it's athletics or, fertility. So you need a full evaluation to see where you stand first. Tip number one, don't waste time. That's maybe the most important thing. You do not have time. The person that says just relax and don't worry about it is not helping. You can work to relax, as I know you will help your patients do and your clients do, but don't worry about it is not a good thing. The second is trying to get into as good a framework as possible for what is a bit of a long journey. We all hope this will work with a single swing at a pitch, but I think it's better to be prepared for a longer journey. And you need to be in as good a health, your health parameters should be in as good a place as possible to prepare yourself for the journey. And this may segue to another question, but things like your lifestyle, what you're eating, your sleeping, cutting down. You don't have to eliminate alcohol completely. I think the French have children. So having an occasional glass of wine is fine. But if you're fine, I have 2-3 glasses of wine when I get home at night, that should be cut down. If you're a smoker, it needs to stop. Marijuana, we don't have great data on it, but there's nothing to say it helps pregnancy. I would strongly recommend, certainly if you smoke, but even edibles, I would make that go away when you're trying to get pregnant. And I would think for those that have a male partner, I think that'd be important too. Is there a fertility diet? There is not. I think it needs to be a balanced diet that that you are comfortable with. And I think the key here is going to an extreme where you're really, I'm having a diet, I'm miserable with this, whatever I'm eating. But what does that accomplish? I think you want to be in a place that is healthy, that's good for you, that your lifestyle is good, exercising, getting your weight in a good place. These are all critical things, but move along with the process at the same time.
Great. Okay, thank you. Another question that I got was, this one lady keeps experiencing cramps after the embryo transfer, and then gets her period even before the 10-day or 14-day wait, before the first beta test. So what tests are available out there or at CCRM that you could do in terms of implantation viability?
There are a couple of different issues. Cramping is not that unusual after several days after transfer. It can be part of the implantation process, so it may not be a bad thing. Obviously, for the person who asked the question, was not a good thing. But I think when women have multiple, I'm answering in a more broad way, who have multiple unsuccessful transfers, then I'll look at it several ways. One, was the embryo genetically tested? If the answer is no, that's a critical next piece, because an embryo that may look beautiful may not be normal. So that's critical. The second piece is there are various tests that do look at implantation. One which is, and none of them are standard. They're all controversial because the data is not wonderful. But one, we all call them biopsies of the uterus, so they're not happy for anybody. One is simply called a therapeutic biopsy, which is where the doctor goes in and basically kind of scrapes the uterine line, and not a happy moment. But the theory being that it creates an injury, and when we create an injury, kind of all the healing cells come in there. That's not been shown to be helpful for a first transfer. It may be helpful for prior failed transfers. The second is what's called an ERA, or endometrial receptivity assay, which kind of looks at genes that are turned on or turned off. That also requires a biopsy. It's a little more controversial because the recommendations that are associated with this, which is take progesterone for longer or shorter periods of time, actually haven't been shown to be very valid in being effective. But it is a test that has been done. And then the third are looking at a set of proteins, also a biopsy, unfortunately, that reflect either inflammation in the uterus, what's called endometritis, that's often treated with a long course of antibiotics, or abnormalities in certain proteins that are often associated with endometriosis. So all those things are things that we can look at. And there are also techniques to try to keep the uterus a little more peaceful, acupuncture, various doses of antihistamines, steroids that can be used as well. So a lot of this is empiric, I will be the first to admit. But I think when you've had one failed transfer is depressing and miserable, but isn't a trend. But what your client has described is indeed a trend. And I think it needs more than, hey, let's just swing at another pitch and hope it works.
Right. Okay, thank you. You've been talking about genetic testing a few times now, and one of the questions I got was, if my embryo is tested and cleared, why do I still experience a miscarriage?
That's a great question. We found when we look at our own just data over the years, we find that transferring a normal embryo still yields about a 5% miscarriage rate. And there are several reasons for that, possible reasons. One is understanding the limitations of that chromosomal testing. It basically says all the chromosomes are there, normal male, normal female, but it won't drill down on little deletions or additions of chromosomes that could theoretically result in a pregnancy that isn't viable. Unfortunately, we don't have the technology to do that today unless we knew exactly where the deletion is. That's one bit. The other is the implantation part we just talked about. And the third is I'll often do an evaluation for recurrent pregnancy losses, blood clotting abnormalities, hormonal abnormalities, make sure there's nothing wrong with the uterus, if no one has evaluated the uterine cavity, making sure there's nothing else that could lead to pregnancy loss. There are still rare patients where we've done everything we can possibly do. Every test, every manipulation, and they're still miscarrying. And you have to kind of say what no one wants to hear is that there is a fundamental problem with the uterus that in 2021, we don't understand. And do you consider someone else carrying the pregnancy? Or tough thing to talk about. Yeah. Sometimes we do have to have that discussion, and oftentimes the outcomes are fabulous.
Right. If those patients then would opt for donor eggs, how would that improve their chances if you still don't know what's going on? I know that's a very broad question.
Yeah, I was actually suggesting a gestational carrier in that situation, okay, as opposed to an egg donor. Because then if the uterus is the problem, and now a woman carries the pregnancy who has had uncomplicated pregnancies in the past, because she has to be a gestational carrier, you kind of get around that issue. But you're right. Using an egg donor, the only reason you could hypothesize that an egg donor may be more helpful is the part that I first talked about, is some genetic problem that's less likely to be the case with a young donor's eggs. So that will be a little more likely to be successful, but your point is well taken. If the embryo is normal, this sounds silly, but is normal equal to normal? And there still are differences with 25-year-olds eggs, 42-year-olds eggs, even if the genetics are the same.
Absolutely. Okay. And that brings me to my last question for today. What are some of the cutting edge treatments that you offer at Lone Tree or within CCRM versus maybe other more standard clinics these days?
Well, I never like to compare to other places, but I would say that just in general, here, although I like to take full credit for everything, it's lab, 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 and lab.
Yeah.
And to have, and it really is a huge difference from one lab to another. And one thing that's excited me over really since I first joined CCRM is that we are one of the few programs in the world that has a very active research program. And the average person might say, well, so what? You publish a couple papers out of this. But it's more than that, because these are little things that can be changed instantaneously. If I'm at a smaller clinic and I hear a presentation at a meeting that sounds interesting, I wait till it gets published, and then maybe I'll try it, and it's now 2-3 years from now. We can put it into effect tomorrow.
Mm-hmm.
And I look at just the lab part as almost like driving down a highway, where you might think it's straight, but maybe in Wyoming you can drive straight just like this, but because there's no other cars. But in all seriousness, you never really hold your steering wheel straight, right? You're always adjusting. That's what we're doing in the lab all the time. We've done a lot of work with in vitro maturation, trying to mature eggs in the lab. This has been very helpful for 2 classes of patients. The PCO, polycystic ovary patient, where there's lots and lots of eggs, is at a high risk of hyperstimulation. Then the poor soul where we're just not getting very many eggs. We're concerned that the drugs may have a negative impact on egg quality because they're so fragile. We mature them in the laboratory. We're also one of the only clinics that does this chromosomal testing of embryos in-house. We do not use outside labs for this. And I think that plays a critical role in quality control. We're even doing cancer screening on embryos, the BRCA mutations, for folks that are carriers in-house as well. And then lastly, I think in terms of freezing for vitrification, we've been ahead of the pack for a lot of years on this for both egg freezing and embryo freezing, the former for fertility preservation as well. So there's things that are changing all the time. We're currently, and I'll put one little plug in just because I'm excited about this. We're doing a research trial we just started in the last month or 2 for women with endometriosis, which is a devastating disease, who are also doing in vitro. And it's looking at a new drug that's been recently approved for endometriosis pain called Orlissa, it's a tablet, to see if that can help implantation rates before transfers. And it has a bunch of financial advantages for people that are in the study too. So we think this could be a great advance and make things a little more pleasant or less unpleasant, depending on how you look at it.
Wonderful. That's a great message of hope for all these women out there. Thank you. I've got one personal question. What do you like most about your job? What gets you out of bed in the morning to go back to your workplace?
The alarm clock gets me out of bed in the morning and the dog on my head. But that's probably not what you're asking. You know what? I've been doing this for a while, and there's every day is exciting. It isn't repetitious. Because it's not, my field is not like a problem. An orthopedist, that your arm is broken, it's broken. Here, I have 1 or 2 patients together that everybody is unique because the situations are unique. And when I look back to doing IVF years ago, I almost felt like an oncologist. I was just calling it bad news all the time, and we were still better than just about anybody else. But with a 30% success rate bad in 95, that means most people aren't getting good news. It's the complete opposite. And the cool thing is, even when I don't give good news, I can now at least say, we've got bad news, but I think I know what the problem is. And we never used to be able to say that. So it's just a kick. When I get, Christmas is great. I get these cards from kids that, I just think, I can't believe I'm that old, but it's really cool just to see these kids grow up and feel you play just a little role in them.
They must be in their 20s now. Oh, wonderful.
Let's not go there.
Before I let you go, one last piece of advice for all these women out there who want to get pregnant in 2021.
Well, it's a unique year for sure. And so I'm going to give two pieces of advice. One is, if it weren't a COVID time, which is don't delay. If you are worried about your fertility, then you should pursue this. Don't listen to folks that say don't worry. And it may be there isn't a problem and you haven't tried very long and there's nothing wrong. But if you're worried, you should have your concerns addressed by someone who is skilled and caring, and make sure, and this should be looked at in a holistic way. Specific to the crazy time we live in, my personal belief is get vaccinated. If you're in the middle of fertility treatment and you say, should I get vaccinated and have my transfer at the same time? I'm a little conservative. I would say get vaccinated and wait just a few weeks before you get a transfer. But this is a devastating pandemic, and we're getting a handle on it. But life isn't going to be perfect next month. You should not put off trying to get pregnant, though. No one is recommending that. But be careful. Be cognizant of this. There's no place not to wear a mask. There's no place not to social distance, no matter where you live in this country. So that's my last advice for this year.
Thank you so much. So important. All right. Thank you for your time and good luck with your work. And I'm very excited to hear about the endometriosis research and hope to speak to you again anytime soon.
I look forward to it. Thanks for letting me join you.